It's the fate of about 10% of all American adults to end up with an ulcer of the stomach or duodenum. In most of them, probably well over 90%, the ulcer heals under medical management, as you know, and no surgery is ever required. It's the indications for surgical intervention and their best methods of operative management that occupy the next 60 minutes on Audio Digest Surgery, Volume 18, Number 7, Perspectives in Managing Peptic Ulcer Disease. The first of our 5 discussants, 4 from the Cleveland Clinic, 1 from Ohio State University College of Medicine, is Stanley O'Herr, comparing indications for and results of several of the surgical approaches to duodenal ulcer. Dr. Herr believes surgeons have learned to be conservative, conserving stomach, in dealing with most duodenal ulcers, and he, along with most surgeons, does a variety of operations for duodenal ulcer, depending on the circumstances.
One situation, routine ulcer or scar in a supple pyloric area, not bound down. This is suitable for a Heineke Miculitz pyloroplasty plus a vagotomy. The Finney pyloroplasty is probably a better pyloroplasty than the Heineke Miculitz if there's scarring. Undoubtedly empties better and probably will have a lower recurrence rate when the end results are in. If there's an inflammatory mass or severe scarring, my own feeling is to stay just as far away from it as possible. This can be done either with a posterior gastrojejunostomy, a dependent anterior gastrojejunostomy. I tend to do anterior gastrojejunostomies because they're easier for me, and a cross-cut type of gastrojejunostomy. As an alternative, the side-to-side gastroduodenostomy, which is so logical and so simple that you wonder what kept us off from thinking about it a long time ago. And I think many of us are using this as almost the procedure of choice in preference to the average pyloroplasty. Gastric resection will be indicated in some people. If there's a coexistent gastric ulcer, it certainly isn't wrong to remove the gastric ulcer, but the ulcer does not need to be removed unless it can easily be removed. You need to get all of the antrum and get a secure closure of the duodenal stump. But lives have been lost that I know about by surgeons attempting to excise an ulcer which should not have been excised. I reserve a vagotomy with a gastric resection for patients who are simply not going to want any further surgery for duodenal ulcer. It certainly is the most effective operation as far as recurrence of an ulcer is concerned, and the recurrence rate quoted by many different centers is of the order of 1 to 2%. Progress has been made in the state of Ohio. The Ohio chapter sponsored 2 surveys 10 years apart, which were conducted through the chapter members in Ohio. And the first one had the same objectives as the second one, which was conducted 10 years later. Very simple objectives. What operations Ohio surgeons perform electively for chronic duodenal ulcer? What is the mortality rate for these operations? What are the qualifications of the surgeon? The second survey had more participants than the first survey. It's a wide variety of hospitals, a wide variety of communities, and a sizable series of patients. The individual surgeons who participated in the second survey, most of them had participated in the first survey as well. Now, what was the progress? The progress was in mortality that was reported. There was a 4% mortality in elective operations that came to light in the first survey. Really far too high for a so-called elective operation of any type. That dropped to 2.6%. Resection plus vagotomy had a drop in mortality rate, undoubtedly is a better selection of patients. Drainage only and vagotomy held fast for mysterious reasons. High mortality for a relatively simple operation, but undoubtedly was done in the worst risk patients. I think the value of the survey was not in the people that read about it, but in the institutions evaluating their own results and often finding a surprisingly high mortality which they simply hadn't suspected. Now, in terms of what was being done, the incidence of gastrectomy went down, the incidence of vagotomy doubled, pyloroplasty was discovered. Now, in dealing with results, I'm going to turn to my own hobby, the ledger dealing with duodenal ulcer, which I started in 1950, which certainly can be criticized and undoubtedly will be, but it stands for results that I know to be true, and it's based on patients that I personally have evaluated, operated on, and followed. I have pretty close to 100% follow-up on all the patients that I've operated on for duodenal ulcer since 1950. I've done this through a very devoted follow-up secretary and through my own office, because in my experience in several other institutions, I found that the record rooms and the hospital personnel were not able to do it on an impersonal basis. It took a personal interest in a particular individual. What I was interested in doing was not in comparing my results with other people's, because duodenal ulcer is a highly subjective disease and surgeons are highly subjective people. You undoubtedly might pick patients for operation differently from the way I do, but I've tried to think that I've picked patients consistently the same way during the 20-year period that the study covers. I've followed these people mostly by questionnaire, and I've graded them according to what I considered the result to be. Again, somebody else might not grade them the same way, but I've tried to be consistent, and I think I can honestly say that I really didn't have any foregone conclusion as to which operation should be best. I just wanted to know how these operations turned out, and I had a conviction that you had to follow people a long time, preferably to their death, to find out exactly what the end result of a particular operation was going to be. Now, in the last 20 years, I've gone through what I regard as 3 eras, and even in an era when vagotomy and posterior gastroenterostomy was the operation that was being most frequently done, there were still cases which I did as a gastric resection and an occasional vagotomy and gastric resection toward the end of that time. The gastric resections were mostly for acute hemorrhage. In the era of vagotomy and gastric resection, there were still people in which it seemed best and safest to do a vagotomy and gastroenterostomy. Pyloroplasty was discovered in this period. There were still occasional gastric resection patients. And now in this current era, we're still doing an occasional vagotomy and gastroenterostomy, an occasional vagotomy and gastric resection. We picked out 100 consecutive patients in the era 1950 to 1952 that had vagotomy and posterior gastroenterostomy. And here's the 2 ways of looking at how you can size patients up. 64% were always a good result. 16 had died as a good result of other causes. There was a temporary failure in 30. Now, this is quite a large number. 23 had significant symptoms. 23 living, 7 dead of other causes. 6, a poor result, 5 living, 1 dead. 11 secondary operations for recurrence. Only 7 ulcers demonstrated, but I'm convinced these people get a gastrojejunitis for all intents and purposes might be an ulcer from which they bleed. Era 2. And most of the follow-ups in that initial group were 15 years or longer. In this group, the follow-up is 10 years or longer. 66%, always a good result. 21%, a temporary failure, then asymptomatic. But the failure, this is another thing that has not always been recognized in the old literature. You can be a miserable failure as a result of the dumping syndrome or a whole host of symptoms that didn't exist before your gastric surgery, which may be more disabling than a recurrent ulcer. And if part of the stomach has been taken out, the art of transplantation hasn't reached the point where it can be put back in again. Whereas if you've done a conservative operation like a pyloroplasty or gastroenterostomy, you can always take a part of the stomach out later on. 13, a poor result, higher than in the other group. Vagotomy and pyloroplasty, a good result, just about the same. 8 secondary operations. The follow-up here is only 5 years or more for the most part, and undoubtedly the poor results, the failures will mount somewhat with the passing of time. In my own practice, I saw one patient who had a gastric resection who developed his first symptoms of a recurrent ulcer 26 years after his gastric resection. Now, this is the way the 3 operations stack up. About 64 to 69% were always a good result. There's a residual of around 10%, a hardcore residual for a poor result. And in my own thinking, I felt that this probably represents an irreducible minimum, and it represents a type of patient, a dissatisfied type of patient with a miserable gastrointestinal tract or a miserable temperament, one or the other or both, who are not going to be benefited permanently no matter what you do.
Turning now to the causes of recurrent ulcer, here is Ohio State University's Robert M. Zollinger discussing technical errors in surgery, unphysiologic operation, drugs, and ulcerogenic tumors.
We've looked up about 125 recurrent ulcers that came to us and tried to decide what was really wrong, because after all, medical treatment is directed toward the control of the acid factor, and the surgical treatment is after the control of the acid factor. And in these failures, we felt that about 83 of the 125 had had the proper operation, but there were technical errors. The retained vagus, particularly the posterior one, is the main one that the boys continue to miss. I don't suppose I've had a resident that hasn't missed a couple of posterior vagus nerves. Then others had an inadequate resection or a nitpicking operation or a gastroenterostomy put too far to the left, and a couple had retained antrum. Then there's other cases, quite a number, that have had a non-physiologic operation, in other words, gastroenterostomy without vagotomy, and I think Stanley's survey made a great contribution to the surgeons in making them think and evaluate what they were doing, that we won't see so many of this cause. But as we've looked over our recent cases the last couple of years, we've been surprised yet to find that, for example, I think the other day there were 26 patients with recurrent ulcer that had vagotomy, yet when they re-explored, 17 of them had the large posterior vagus nerve still remaining. Now, in doing a gastroenterostomy, Dr. Hurst said he liked to do an anterior one, and so do I. And I think, by the way, when you get a recurrent ulcer, you should send away and get the operative note if you can get it. And then when you look at your x-rays, see where the stoma is. Because after all, if your patient's on the obese side, if they had a lot of inflammatory reaction, you just can't do a proper posterior gastroenterostomy. It's always too far at the left. And for that reason, split the omentum and do an anterior gastroenterostomy and have a measuring stick in your kit. Every surgeon should have a centimeter rule or an inch rule or something always boiled up so he can sort of measure and keep himself in tow as to where he's putting the stoma. As the great Dragstead says, this should be within 4 centimeters of the pylorus. This is hard to do posteriorly, and I've just given up trying to do it. The other thing I think we've been interested in, trying to cut down our failures with pyloroplasty, is to make sure we don't get antral sag. And visiting Japan last year, the Japanese surgeon has, for the first time, begun to swing a little bit toward the more conservative procedures, because there they fear cancer so much that they take out everybody's stomach. That when you do your temporary gastrostomy, or when you finish your pyloroplasty or conservative procedure, tack your antrum up to the peritoneum so it maintains a straight line with the pylorus. Otherwise, you'll have a J stomach, again antral distension, production of gastrin, and this may well account for many of our failures, and we've seen that happen. So pay a lot of attention to how you do your particular fixation of the antrum. Just don't do your gastrostomy any old place. Now, since vagotomy is not complete in too many instances, and one of the reasons why you have recurrent failure, I think we ought to talk about that just a little bit. I like to do a midline incision, and if there's any difficulty to the exposure at all, I invariably remove the xiphoid. This is rather easy to do, and you need only one transfixing stitch on either side to control the bleeding, but it gives you better exposure. I also reflect the left lobe of the liver, and the other thing I would recommend to you, that you cut the uppermost portion of the gastrohepatic ligament. It contains a blood vessel, branch the inferior phrenic, transect it with your long right angle clamps, and then you can get a good exposure posteriorly so you don't overlook the posterior vagus nerve. We have a stomach tube in place, we've had a small S retractor holding up the esophagus, and you get a pretty good exposure. Now, as I said before, if it's a problem case and you have recurrence and a lot of acid, or it's a failure after pyloroplasty and recheck, we haven't hesitated to really go back to the hemogastrectomy, because if you control the cephalic phase and you control the gastric phase by antrectomy, you can do the Smithwick-Farmer hemogastrectomy or the Edwards hemogastrectomy by going to the third vein on the lesser curvature and take the point on the greater curvature where the blood supply is nearest the greater curvature. That gives you removal of most or all of the antrum. And we always mobilize the spleen and try to convert back to a Bell-Roth 1 type of procedure. Now, although from nutritional studies and metabolic studies, the Bell-Roth 1 always looks good, I really have to confess, as Stan and I were talking over the phone the other day, as you look over your cases, you have trouble with all of them. And I think anytime you tinker with the human stomach, you have some trouble with it. And I was never able to really pick out and say, this is wonderful, the weight is the best, the symptoms are fewer, and all the others, because I've always been more concerned with the side effects of the operation other than the instance of recurrent marginal ulceration. Now, one of the things that Stan mentioned about bleeding, I think we're always discouraged, as you are, when a patient comes back, they've bled, it's always sent in with a recurrent ulcer. Your medical friends have keen glee in telling you you've got a recurrent ulcer. I don't know, it seems to give them great joy. We see a number with drugs. As he referred to people that bleed, I think that a number of people are bleeding today, and we condemn the operation when actually it's the drugs they're taking for their arthritis or some other cause. So you must always look whether it's drug-induced or not. The patient that has arthritis, migraine, hypertension, a person with knobby fingers, find out about it. And they may well be on a drug given by their physician, or they may well be taking drugs themselves. And I've been impressed by the fact that patients are loath to tell you whether they're taking any self-medication or not. If they say, yeah, I take a little aspirin, I always ask, well, how do you buy it? If they say they buy it by the 100, then I'm in business. I know they're taking more than they admit, because they wouldn't try to get it so cheaply. So that I think that you have to remember that self-medication may be more important with gastric ulcer than it is with some of your other ulcers. But I've been impressed with a number of physicians who will tell the patient perhaps not to drink coffee, but permit tea, and iced tea, and Coca-Cola, and all the other caffeine-containing drinks. These are the things you have to check, because some people take 10 or 15 cups a day and it just gets out of hand. We've seen perhaps more endocrine causes than you might see. There's 700 cases or more ulcerogenic tumors that have been reported. And one of the unusual things about them, I think, as recurrent ulcers, and we're talking about the problem ulcer case, is the fact that you see a primary ulcer beyond the ligament of Treitz. This is rather unusual. You're seeing it a little more today with the patients taking potassium and other types of diuretics and so forth, but it's rather unusual. Furthermore, obstruction is rather unusual because they have a fulminating type of ulcer. They do not have a chance to heal, resolve, heal, and then scar. They stay right with it with some of the more traditional complications. As you know, X-ray man can help you now making this diagnosis. Beside the history, you're always thinking about it. Now, if you had a patient hardly had any room in their stomach for barium, you'd know very well that a vagotomy and a pyloroplasty wouldn't work, and a big duodenum with an impaction, which was really a tumor, you'd know that this patient probably is going to have difficulty, and an aortogram shows multiple nodules through the liver. Well, with all the symptoms of an ulcerogenic tumor, you are justified in trying to establish the diagnosis, perhaps further by gastric analysis. And we observe today that surgeons don't pay too much attention to gastric analysis. Our medical friends don't pay any attention to what we say unless we place it with a fluoroscope. If you're investigating very severe ulcer cases, making large volumes of gastric juice, you'd better put a needle in the vein and let Ringer's lactate or some other balanced solution run in all night. Or you won't be able maybe to get the proper readings that you want the next day. Try to keep their weight pretty even if you can. Now you see the stomach with the ulcer is making all the acid it can, regardless of what surgery you've done before. A man who just went home Saturday making 106 milliequivalents in 1 hour. You give him histamine, he can't make any more because he's being stimulated to his maximum. So the ratio between his basal and his stimulated is 1 to 1. Now, one of our old residents, Dr. Passero, has been talking to Pacific Coast Surgical and written elsewhere that if you give a calcium infusion test and raise the blood calcium, you will get a further stimulation of gastric production because a high level of calcium in the bloodstream brings out gastrin and will stimulate the production of hydrochloric acid. This patient goes to 138, which is diagnostic of an ulcerogenic tumor. We've used the rat bioassay, which is just an isolation of the stomach of the rat, and then measuring the output of acid. If the output of acid doubles after you inject the patient's serum over the baseline, you think that this is diagnostic. We've done this test now 300 or 400 times. Sometimes it works and sometimes it doesn't. I think we'll all have the advantage of McQuiggan's gastrin immunoassay before long, because he feels that about the only use maybe at the moment that they know for sure about is in diagnosing these severe ulcers or recurrent ulcers associated with ulcerogenic tumors. Whenever there's low acid, of course, the gastrin goes up, as it does with pernicious anemia. So don't forget that. You may get a high level with no acid because in the absence of hydrochloric acid, there's an overproduction of gastrin as well. But the tumor levels are quite high, and everybody should have this before very long, should have the gastrin immunoassay that will help you ferret out these difficult ulcer patients and tell you whether or not total gastrectomy is indicated. They lose a lot of fat, a lot of these people that are making too much acid, because as you measure the pH in the duodenum, it's at an acid level, and they just can't adjust their fats, and accordingly they lose weight, and they have a steatorrhea because they have a loss of about 75% of their fat. We still like total gastrectomy for these reasons. The patients have a high degree of malignancy with these ulcers. They scatter around, metastasis, multiple in the pancreas, and if you want to just take out a simple tumor itself, you'll get a recurrence in 60%. Actually, the first case I did in 48 had a simple excision, the left half of the pancreas, lived for 4 years without a recurrent ulcer. But don't bother around if you think you've got a tumor of the pancreas with a radical operation. Either do nothing, take the tumor out, and do your favorite operation, or take it all out, because you'll be doomed to failure unless you do. And in general, Friesen has pointed out, if you take out all the stomachs, that perhaps these nodules will regress. Some people think it's an immune destruction. Some people talk about an inhibition of the gastropituitary axis. I like to read this because when I finish, I've already said more than I know about it. And I think that that's probably what the fellow that wrote about it in the same category. But you will see if you do too many operations, do a little and then come back and keep doing it, you lose about 1 out of 3 patients. If you're aggressive and do a total gastrectomy, then you will cut your mortality in half. And I would never do a total gastrectomy unless I had microscopic proof of an ulcerogenic tumor. It must be seen under the microscope before I would do it.
Bleeding indications for surgical intervention include continual massive bleeding, requiring transfusions on a daily basis, and recurrence after bleeding is once stopped. Here now to consult on your management of upper GI bleeding are the Cleveland Clinic's Eugene I. Winkleman on diagnosis and medical treatment, and Robert E. Herman on surgical treatment. Dr. Winkleman first points out that hematemesis and melena are almost invariably secondary to upper gastrointestinal tract bleeding.
Upper gastrointestinal tract bleeding is defined as bleeding which comes from a source above or proximal to the ligament of Treitz. Melena, which in this instance is defined as tarry black stool in opposition to hematoschizia, which is red blood in the stool, is almost always from above. We all know of particular instances where it may come from the right colon. I've even had a friend who was rather radical and said he'd seen it come from somebody who'd had internal hemorrhoids which bled. I kind of look at that askance. And just as you may have black blood from the right side of the colon, you certainly may have red blood, which is passed per rectum, but which comes from a source proximal to the duodenum. And a rule of thumb that I have is when the color of the blood coming out of the nasogastric tube is equivalent to the color of the blood coming out the rectum, that's the time when you call for your surgical colleagues and don't even attempt to look wise. The problem of tarry stool is one of volume of blood in the stool as well as transit time. And there are various and sundry figures given, but supposedly 60 to 100 cc's of blood in the gut can give you a tarry stool if the blood has remained in the gastrointestinal tract from anywhere from 6 to 10 hours. And there are almost as many different figures as there are different reports. The most important thing about this, however, is that you must realize that hematemesis and or melena are signs of organic disease. They're genuine and they require our full energies in elucidating their source. And these are the statistics from 750 cases of acute gastrointestinal bleeding, upper intestinal bleeding. Duodenal ulcer, not 75 to 95%, but 27.7%. Varices, 18%, which is a little higher than what we believe is true. Gastric ulcer, gastritis, 12.6, esophagitis, 6.6, Mallory-Weiss, 5.1, which I think is a very amazing statistic. Anastomotic ulcer, and others. Certainly, the type of hemorrhage that you see is different, varying from the person who has a massive hemorrhage which brings him to the emergency room in shock, as opposed to the patient who comes to your office and says they've had several bouts of black stools, which they're a little bit concerned about but have no symptoms. And what I'm talking about essentially here are the individuals who come to the emergency room or come primarily because they're alarmed by the sudden occurrence of blood loss. We feel that a quick, precise diagnosis is imperative. We also feel that there are several deterrents to make a quick, precise diagnosis. And these deterrents are, number one, our tendency to play the statistical odds that most of the GI bleeding comes from ulcer disease. The statistics quoted are 75 to 95%. We tend to play the odds that cirrhotics who have varices are bleeding from varices rather than from other lesions. Number two, we have a tendency to feel that if somebody has had a definitely shown lesion which has previously bled, that if they bleed again, they're bleeding from the same lesion. And of course, the third and last one is our fear of aggravating hemorrhage and the consequent kid glove treatment that we give people, i.e. we're afraid to pass tubes, we're afraid to palpate their abdomen, we're afraid to manipulate them. So this means that we have to challenge our statistics as they must be viewed in terms of the criteria that has been made for diagnosis. Now, we can't argue with what you find at operation. We can't argue with what the pathologists find at the autopsy table. But we must realize that x-rays do have their limitations, and x-rays don't show shallow lesions. They can't show an erosive gastritis. And oftentimes when we wait a week or 10 days afterwards to get our studies, that they might not show other lesions that have been there. So essentially, this is a pitch for a vigorous diagnostic approach. A vigorous diagnostic approach which utilizes endoscopic and radiological techniques. The catalytic agent in this is a man by the name of Eddie Palmer, who was a gastroenterologist primarily in the military, and since he's retired, he's now at the Veterans Hospital in one of the eastern states. He has made this pitch that we use endoscopic evaluation immediately. This was very difficult for a lot of people because of the use of the rigid instruments which we used to have. But with the development of the fiber optic instruments, we get excellent visualization. Once we've done our endoscopic procedures, we previously would send them to the X-ray department in order to have the usual barium studies done. Recently, we've been more in favor of the use of selective celiac catheterization. Our radiologists are most agreeable. They'll come in at any time, and they're very skilled with their interarterial catheters, and they can go in and catheterize the celiac axis and inject material. And if these people are bleeding enough, they can localize the site of bleeding. Evaluate the individual as you would do. You do this historically. Have they bled before? Have they required transfusions before? Have they had difficulty with transfusion? Do they have a family history of it? You look for the cutaneous manifestations to find bizarre type of things. If you have the chance in the emergency room, you look for zebras and canaries. If you don't have time, then you just evaluate the person, replace their blood. We have a big problem with our younger men is the fact that they want to run this show on the basis of the laboratory. And I don't think that we've yet replaced the ability to evaluate these people on the basis of their vital signs, their blood pressure, their pulse. Some people advocate the use of the tilt table, where you tilt the person up to 75 degrees and evaluate their blood pressure and pulse. Most of us don't have these things available, and a very simple means of doing this is just to have the patient sit up, keep them up for a minute or so, and find out what happens to their blood pressure and pulse. And this is what we use as a means of evaluating blood replacement. The other problem we have is the use of a nasogastric tube. Now, there seems to be a penchant among young people to want to put tubes down people. And I guess maybe they stopped having them pass tubes on themselves in medical school, because I've never forgotten my first very traumatic experience and the times when I've had to do it since in the interest of science. And I think any time you can avoid a tube, you certainly should. On my own service, I avoid it, and the only instance that we have for a tube is if they want to pass a tube initially to find out if there's blood in the upper gastrointestinal tract, I don't object, or if the patient is vomiting and unable to eat, then they have to be put on it. Apart from that, I think they should be fed as quickly as possible. And I'm a heretic. I don't believe in all this dietary nonsense. I give the patient what they can tolerate, divided into multiple small feedings given throughout the day. I'm sure you all realize that the worst place in the world for a patient who has an ulcer, who needs a diet, needs food when he wants it, is the hospital. And you try and make the best of that particular situation. We give them multiple small feedings. We alternate milk and antacids in between these particular feedings. We stress this very much. I don't believe in the use of anticholinergics routinely. I think the potential side effects of these far override the potential benefit. And you're all aware of these, particularly in older people, in which you get in men who have got BPH, who get urinary tract retention. We've seen glaucoma produced that has a tendency to dry up their secretions. We can get peritonitis and all the other complications besides making the patient uncomfortable. So I don't think that anticholinergics necessarily play a role in this. Bed rest has always been stressed, and I think it's important, but I think it's important only as long as the patient is weak and is hypotensive. We want to follow the same techniques here that we do elsewhere. Get them out of bed as quick as we can. Don't run them up and down the hall, but mobilize them and move them about.
Before hearing from Dr. Winkleman's co-discussant on upper GI bleeding, Dr. Robert E. Herman, let me signal the end of this side of your program, Doctor. Side B can be heard by just flipping over your recorder's cassette or 2 reels. Continuing a program on perspectives in managing peptic ulcer disease, this is Audio Digest Surgery, Volume 18, Number 7. Now, resuming the discussion on upper GI bleeding and peptic ulcer disease, here is Dr. Robert E. Herman with some thoughts on surgical treatment. In particular, when to operate, which operative procedure to use. He recommends vagotomy and pyloroplasty for the critically ill, poor-risk patient, vagotomy and antrectomy for the younger patient able to tolerate it, and what the unacceptable mortality rate is.
When do you operate? If the patient is a slow bleeder, that is, he only has melena, requires maybe 1 or 2 units of blood or 3 over a period of 3 or 4 or 5 days, I think it's perfectly safe to undergo a diagnostic effort and let the patient see if he won't stop on his own. I'll go along with this sort of thing for 4 or 5 days perhaps. On the other hand, if the patient is a rapid bleeder, a more severe bleeder, then I think you've got to operate a little faster than that. There's no question that we weaken patients by waiting too long. I generally use, as a rule of thumb, 6 units of blood. That's half the blood volume of the body, and if the patient has lost 6 units of blood and continues to lose it, then I think about that time it's time to operate. This may be a rapid loss of 6 units of blood, or it may be a slow loss over 3 or 4 days. If the patient has bled once and stopped, and then has recurrent bleeding, if it's recurrent right there at the same hospitalization, I think you should operate. On the other hand, if the recurrence is 6 years after a previous bleeding episode, and the first bleeding episode wasn't too severe, and the second one isn't too severe, I think it's permissible perhaps to try to institute an ulcer regimen again and wait for a 3rd episode. Somewhere after the 2nd bleeding episode, or certainly after the 3rd bleeding episode, I think surgery should be advised. So that I think these are problems of judgment. Some of the aspects of the history and the diagnostic effort influence our decision. If there is a previous ulcer history and the patient has bled on medical management, then obviously you should go ahead with surgery after 1 bleed, perhaps. We're more quick to operate on a massive bleeder if they're an older patient, because we know that they're less likely to stop. A young patient, we're more likely to play out the time a little bit. If it's a demonstrated lesion, we're more likely to operate. We're more likely to operate on a gastric ulcer than on a duodenal ulcer. Gastric ulcers don't seem to stop quite as frequently. Now, when the surgeon operates, especially in the emergency situation, I think it's important to get a good look at the interior of the stomach. And I would emphasize this long gastrotomy opening. We open this so widely that I can put retractors in the stomach, regular right-angle Richardson retractors. We'll put some packs and tapes in there, and we'll frequently evert the entire stomach through the opening, pushing it up so that we can wipe out the folds and look for hidden lesions, especially around the cardioesophageal junction, the Mallory-Weiss tears that Dr. Winkleman mentioned, small ulcerations, hidden ulcers in the body of the stomach. And then we'll make a 2nd incision across the pylorus frequently, and again make this big enough so that we can get a good look of the whole area, look down in the duodenum, and look for ulcerations. I think this is very important. If the patient has an ulcer that we see, and it's a young patient, he's a good risk patient, and particularly if there's been a past history of ulcer disease, then I think the disease is virulent enough that I would go for the best operation that I can do, and that is a vagotomy and an antrectomy. On the other hand, if the patient is an older patient and a somewhat poor risk patient with ulcer disease, I would do a vagotomy and a pyloroplasty, and frequently just a Heinecke-Mikulitz pyloroplasty with oversewing of the ulcer, or a Finney pyloroplasty, which gives us a little further access down into the duodenum. You can extend this incision on down if you want and make a giant opening. Of course, you'll get some dumping if you do that. The bigger you make the opening, the more likely you are to get dumping. Even the patient that's only had a pyloroplasty, you can still see dumping. But I think this is important, and you can tailor this situation to meet the demand. And then, of course, close the gastrotomy incision that you've made. If the patient has a hemorrhagic gastritis and it's diffuse, I may be inclined to go ahead with a vagotomy antrectomy, removing the antrum and doing the best ulcer operation that we can do. If it's a gastric ulcer, similarly, we'll frequently do a vagotomy antrectomy because most gastric ulcers are in the distal stomach. But if it's a proximal ulcer, or if it's an ulcer of the lesser curvature higher up, we may wish to preserve the stomach, especially in an older patient who's somewhat poor risk, and simply do a vagotomy and wedge resection of the ulcer and a pyloroplasty to complement the procedure. The problem of stress ulceration, multiple superficial ulcers. This is a problem of diffuse ulceration. I think it's one step beyond erosive gastritis. It's simply erosive gastritis that's gone on to a problem of multiple discrete ulcerations. These are usually shallow ulcers. They're almost always acute. They're not chronic. And again, if it's a young patient, a good risk, the sort of patient that might have sustained a massive burn or might be septic from an automobile accident or from trauma of one sort or another, then I would go ahead with a vagotomy and an antrectomy. On the other hand, most of the patients that we see with stress ulcerations are in the poor risk group. They're older patients. They're patients who have had cardiac surgery, major cardiac surgery, 5 or 6 days previously. They're patients that are on steroids for arthritis or some other chronic condition, and they're not good risk patients. And in these patients, patients, we've done vagotomy and pyloroplasty and simply oversewed all the ulcers that we see that look like they're causing trouble. And we've had very good results with this operation. I think we've had better results than are generally reported. Well, with the problem of peptic ulceration, this is the incidence that I find of bleeding as a cause or as a requirement for surgery. And these are the operations that I've done. 13% of all the duodenal ulcers that I've performed, the indication has been bleeding. 35% of the gastric ulcers. So that you see it is more frequently an indication in the patient with gastric ulcer than it is in the duodenal ulcer patient. I looked up my own results and the number of patients I've operated on for severe or massive bleeding over the last 10 years, and I find that I've had to operate on 70 patients, which is roughly 20% of all the patients that I've operated on, for massive bleeding. By massive, I mean severe bleeding. It wasn't always a critical situation, but many times it was. I find that 17 patients have died post-operatively, which is a mortality rate of 24%. And I noticed as I look over this mortality rate that not a single patient died of continued bleeding. They all died of cardiorespiratory failure, liver failure, renal failure, or a continuation of the primary disease, sepsis in some instances. So that I think the problem of massive GI bleeding is certainly a serious one, as evidenced by what I consider to be an unacceptable mortality rate, a mortality rate of 24%. And yet I think we're doing better by being as selective as we possibly can be, using the lesser operation of vagotomy pyloroplasty and oversewing the bleeder on the critically ill, the poor risk patient, and going for the best operation on the patient that you think will tolerate it, the patient who's younger, and doing a vagotomy antrectomy in this patient.
Historically, there have been three methods of handling perforated duodenal ulcer: non-operative treatment, nasogastric suction, antibiotics, fluids, and electrolytes; simple closure, the most popular method; primary definitive treatment, vagotomy and pyloroplasty; vagotomy and antrectomy; vagotomy, simple closure, and gastroenterostomy; vagotomy and hemigastrectomy; and hemigastrectomy alone. Let's listen now as the Cleveland Clinic's Caldwell B. Esselstyn, Jr. examines these three approaches.
There are two reasons for discussing this topic today. One is, of course, that I don't think we've ever discussed it before here at the course, and the other is that this may well be an area in surgery where perhaps through the inertia or the momentum of a procedure that we've gotten used to or accepted, we have perhaps closed our eyes to newer ideas or newer concepts in this disease. In 1880, in the Lancet, Redwood first described the non-operative management. And this was popularized and carried forth by Wangenstein in this country in the mid-1930s. And today, non-operative care has come to mean really nasogastric suction, the administration of antibiotics, and of course, fluid and electrolytes to support the individual. Now, simple closure, of course, has gained the greatest popularity. It has been quite successful, and it certainly has been the procedure of choice for the majority of surgeons in this country and abroad. It was originally espoused by Mikulec in 1880. Now, in 1908, Munyon first suggested that perhaps primary definitive surgery should be performed. Now, at that time, it was gastroenterostomy. Today, this has come to mean either a vagotomy and a Heineke-Mikulec or a Finney pyloroplasty, either a vagotomy and an antrectomy, either a vagotomy and simple closure and gastroenterostomy, a vagotomy and hemigastrectomy, or a hemigastrectomy alone. I think what it really boils down to in many instances is that most of us, in an emergency situation with perforated peptic ulcer, with a method which seems to work in our hands, are somewhat loath and reluctant to expand the procedure and perhaps increase the possible morbidity and mortality that we might have in operating on a patient who is in an emergency situation and who does have peritonitis. Now, the record for non-operative treatment depends on the series. Most reported mortality of 40 to 60%. And this is largely, I feel, due to the fact that most of these patients are prohibitive surgical risks. There have been several very highly select studies, even in some younger patients, where the perforation sort of sealed itself, and these were not operative, and these results have been quite good. By and large, simple closure will carry a mortality of anywhere from 2.5 to 23%, again, depending upon whose series you read. But the disheartening thing to surgeons about simple closure, if one very carefully evaluates the follow-up, is that there are a great number of patients who have recurrent symptoms, who have recurrent complications, and who come for further definitive surgery. Now, there have been a number of studies that are of some magnitude that deal
with this problem and have closely examined the late results of simple closure. Now, 9 studies. I think there's been considerable length of follow-up, ranging from anywhere from 1 year to 26 years, and the number of patients are considerable, some series over 800 patients. The important thing is that in no instance was there less than 60% of patients who had recurrent symptoms, and sometimes as high as 75%. And the incidence of recurrent surgery ranged from 35 to 50% patients who had to come back for further definitive surgery. In those patients who were strictly followed for 10 years or more, the incidence of recurrent surgery may be as high as 60 to 65%. Now, the problem that, of course, obtains here is the fact that in doing a simple closure, we have really done nothing to alter the basic etiologic determinants of peptic ulcer disease as we understand it. One might ask themselves, how simple really is a simple closure? I think everybody in this audience who has done surgery for a perforated peptic ulcer appreciates sometimes the technical challenge of closing the perforation. Sutures can pull out. We then resort to either a free or an attached omental patch graft. And even if we succeed in getting the ulcer closed, we're then left with the risk, of course, of subsequent hemorrhage. Perhaps we've even compromised the lumen. There's the problem of obstruction. We've already seen the numbers of patients who have recurrent problems. And not to be ignored, of course, is the fact that these patients can even reperforate. In patients who have once perforated their duodenal ulcer, the incidence of reperforation will range anywhere from 2.7 to 8.5%. So indeed, the record has really not been good. Perhaps one of the problems is that with perforated duodenal ulcer, none of us has a single large enough series to follow a long time. Many of these have been collective series, and I think this is when the true picture comes into perspective. Not to be ignored, of course, is the fact that these patients have a dual mortality risk at their initial closure of their simple perforation, and again at their secondary operation is required. Let us then look at the results with primary definitive surgery in this group. This series dates back to 1937 when S.S. Uden first reported 331 cases with an operative mortality of 7.8%. Probably in the 1930s that was really not bad at all. Certainly techniques of anesthesia have improved, our understanding of fluid and electrolytes, and of course antibiotics have come into being. Since that time, of course, the mortality has dropped. I'd like to say a word about Dr. Aubrey Menard's series at the Harlem Hospital in New York City. In 1961, I spent 2 months with Dr. Menard at the Harlem Hospital, and the reason they embarked their particular interest in primary hemigastrectomy for a perforated duodenal ulcer, their patient population was largely an indigent group. The welfare funds in New York City were not sufficient that these patients could have access to rather fancy diet therapy, nor could they afford the frequent transportation and visits back to the outpatient clinic. And so to try to reduce the morbidity of their ulcer disease, primary hemigastrectomy was embarked upon, and indeed their mortality was 3.1% in 64 patients. There were 2 deaths. These patients did not die of sepsis, they died of delirium tremens, which is a not uncommon complication in the patient population which Dr. Menard has to deal with. These operations were done by residents. It was a Bill Roth 2 with a posterior gastroenterostomy, and there were no leaks from the duodenum. Now, in more recent years, we are getting the results of primary definitive surgery, which has included vagotomy pyloroplasty, and Smith in New Zealand has preferred not to do surgery in the scarred area of the pylorus, but simply closes the ulcer and does a vagotomy and gastroenterostomy. Now, these authors have been quite free to admit that when they first embarked upon this procedure that they were very careful in the selection of patients. Their patients were young, under the age of 55. There had not been a long duration from the time of perforation until the time of surgery. There was not a great deal of concurrent medical disease. And I think also importantly, the position of the perforation. The perforations were not large, and they were not posterior perforations into the lesser sac. As their confidence with the method has grown, they now are including the majority of patients with primary definitive surgery, except those that are prohibitive risks. Now, what about the complications in this group? There have been no cases that I could find where there was mediastinitis reported. There have only been 3 or 4 instances of intra-abdominal sepsis in the form of abscesses which subsequently had to be drained. I think perhaps that the soilage that one sees with a perforated duodenal ulcer is overemphasized, that is the fear of it. This is almost a self-sterilizing chemical peritonitis, and I believe it was Dr. Hamilton from Kentucky who has had an interest in this, and he has cultured these patients and has found that 50% of these will be sterile. In the others, he has found either a light growth or moderate growth, and the bacteria have been of low virulence. He has also found that there is no correlation between the degree of peritoneal soilage and bacterial growth and the time from perforation. I think it's only fair that we speak a minute about the other side of the coin. Since I got things together for this discussion, the Surgical Digest for December of 1970 has come out. Those of you who have read it would probably take me to task, so I'll say a word about that study now. Out from Glasgow, there's a report where retrospectively they have compared primary definitive surgery with a simple closure, and the mortality was higher for primary definitive surgery. There were 189 patients in the group who had simple closure and about 49 patients in the group that had definitive gastric surgery. But if you read the report carefully, you find that in every instance, the patients that had primary definitive gastric surgery, the surgeons felt that the perforation was unsuitable for a simple closure, meaning that it was either too large or it was a posterior perforation and gastrectomy was required. Also, the patients who had primary definitive gastric surgery had a longer interval from the time of perforation to their surgery. They were older patients, and they had a greater amount of concurrent severe medical disease. In our own experience, we don't seem to see a great many perforated peptic ulcers. Nobody seems to want to refer those. The experience over the last 9 years, we have performed primary definitive surgery in 18 patients. These patients have been carefully selected. They have been equally divided between vagotomy and hemigastrectomy and vagotomy and a drainage procedure. There have been no deaths, and the morbidity has been minimal. So we are carefully selecting and embarking on this in certain specific situations. Now, I think the most difficult thing of all, at least for me, was in the course of training, my chief never treated a perforated duodenal ulcer by primary definitive surgery. And I think the thing that concerned me the most was what to do about that scarred white plaque. I think you wonder, if you start cutting that out, when is it going to stop, and when are you going to run into tissue that you will have confidence in that will hold sutures? I think that somehow, sometime in the middle of the night, when you do have that small perforation, you simply have to take the bull by the horns, and if it looks favorable, begin to cut it out, and you will find that indeed, very shortly, you do find at the edges very sound tissue that will hold stitches performed in the hynecumiculates, and you can do the same thing and perform a finiporoplasty if you're concerned about compromise of the lumen. So I think that in summary, the important thing is that the surgeon have in his armamentarium all the methods of treating perforated peptic ulcer. The non-operative method, simple closure, and certainly primary definitive surgery in select instances. The decisions when you are faced with a patient with perforated duodenal ulcer are two. First is whether to operate or not. Second is that at the time of surgery, if the patient is stable with an assessment of the type of perforation and the degree of peritoneal soilage, it is with an awareness of the early and late results of simple closure that the operation is decided upon.
About 7 to 10% of gastric ulcers become malignant, whereas duodenal ulcers practically never become malignant. Dr. Stanley O'Hare returns to the microphone now to discuss resection, simple gastrectomy versus extensive resection, and reconstruction for malignant gastric ulcer.
Before operating on a patient with cancer of the stomach, you should first determine whether you really can effect a cure. And you go over the patient carefully from a clinical and x-ray standpoint to be sure there's no evidence of distant metastasis. If you think distant metastases are present, you verify it by a biopsy. One supraclavicular node that we tried a needle biopsy on wouldn't biopsy, and we studied the x-rays a little more carefully, and it was a cervical rib. One Bloomer's shelf in a lady proved to be an incarcerated retroverted uterus. Hepatic metastases, and particularly with the scan, I think is very unreliable. I hope there are no radiologists here, but so verify it. And If you do have X-ray evidence or other evidence of a cancer of the stomach, you only operate for compelling symptomatic reasons. There are two extreme philosophies about how to go at cancer of the stomach. The philosophy which I happen to have is to deal with the primary without biopsy and with adequate margin. If it's a big primary, you have to make a big operation for it. If it's a small primary, you do a small operation for it. To try to do an extended lymphadenectomy for cancer of the stomach, I think is unrealistic, and to chase up the gastrohepatic ligament, etc., take out the spleen, take out everything in the general area of the stomach that might have lymph nodes, I think in my hands the morbidity and probable mortality would outweigh the probable benefits. On the other hand, Dr. Wangenstein and other like-minded people for years have been preaching bigger operations for cancer of the stomach, and it's fortunate that somebody is checking this out. I don't think it will wash, and I think that the extended operations are not going to be able to show an appreciably greater survival rate. The survival with lymph nodes involved anyhow is 20% or less, so you have to be really quite optimistic about surgery as the ultimate answer to cancer before you do a big operation when you can't palpate nodes. If you do palpate nodes that can be removed that you think are involved, of course you should. Reconstructions after doing a total gastrectomy. A small technical point, do the enteroanastomosis before you do the anastomosis to the esophagus, and you won't have to worry about pulling on the upper and delicate anastomosis in doing your enteroanastomosis. What type of reconstruction you do? I favor a Billroth 1 in general. It's my favorite operation. It's a nice operation. If the ends come together easily, that's what you do. You do your cancer operation first, and you do your reconstruction afterwards without thinking about the reconstruction. Then if it's an easy Billroth 1 reapproximation, you do that. If it isn't, you close the duodenum and you do a Billroth 2. I studied about 150 patients that we operated on for gastric ulcer. About half of them were Billroth 1s, about half were Billroth 2s, and there was no difference in the end result as far as I could tell. So that I don't have any inhibitions about doing a Billroth 2 with the thought that it's going to be worse for the patient. It just doesn't come out that way in my experience. Sometimes it is worthwhile to do an exclusion operation. If a patient is bleeding, say, or obstructed from a lesion, but it's fixed, you can't take it out, you divide the stomach proximally, close that in, and do your anastomosis without actually resecting any stomach. Then you follow with 5FU or whatnot, and sometimes you get a very satisfactory palliation. We can't ignore the gastric ulcer, which may be malignant, if you tend to do conservative operations for a gastric ulcer. If you're going to do a conservative operation for a gastric ulcer, in other words, do a vagotomy and a pyloroplasty or a gastroenterostomy, you have to be essentially absolutely certain that the ulcer is benign. And the ulcer has to be benign before you operate by all the available criteria. And this includes cytology, gastroscopy, and with the improved instruments and the improved runners of the instruments, we get biopsies not infrequently from an ulcer edge and have a fairly good idea of whether the ulcer is malignant or not. So you operate on somebody that weighs 90 pounds and has a gastric ulcer where you don't want to take any stomach out. Your preoperative studies indicate that the ulcer is benign. What do you do in the operating room? The safest is to excise the ulcer. It's really a good deal harder to do this than to do a gastric resection, but it's better for the patient. Other systems, you can do a gastrotomy and take a biopsy with forceps. You can take a swab smear for cytology, and if you have a cooperative pathology department, which we happen to, you can get an instantaneous reading on it. If there's any question about it, you should do a resection. These biopsies should be done with a second sterile field technique, just the way you do a breast biopsy, so that if you've guessed wrong and the lesion is malignant, you're not going to be spreading cancer cells around. But the giant ulcer is almost always benign if it's posterior, and it's a formidable operation to take out the pancreas with the stomach if you're going to do a gastric resection. It's a much better thing to peel the ulcer off the ulcer base, and almost invariably with an ulcer of this type, it will be benign, and you save yourself a big operation, and the patient, I might add, by making sure that as far as you can tell it isn't malignant, and then stripping the stomach off, leaving the ulcer bed intact. The ulcer bed does no harm. Ulcers, which we see very close to the pylorus, just on the stomach side, are almost always like duodenal ulcers in their behavior. But even so, you like to verify it. I keep cards on my cancers of the stomach and gastric ulcers just the way I do on duodenal ulcers. Here are personal figures on patients that I've followed these policies on. Taking as all patients seen, which is an estimate as 100%, a resection for cure could be undertaken in 176, or a little less than half. About 50% of them couldn't be operated on for cure at the time that we saw them, and about 50% of those or less, in fact, proved to be 5-year survivors. But taking that 100% as a base, 17% were 5-year survivors. Altering the base, taking resection for cure as 100%, died in the hospital 15, which is a high mortality, and I apologize for it, but that's the way it is. Dying of other cause within 5 years that might or might not have been cured of their cancer, regarding as an indeterminate case, you come down to 153 determinate cases. We throw these out because they might or might not have been cured of their cancer, so they'd had a more skillful surgeon operating on them. So we have a new 100%. And we find a much better figure for 5-year survivors of a little over 40%, making it not too dissimilar to cancer of the breast, for example. And if the stomach was out where you could feel it and get an early diagnosis and operate on it quick, if there was a little lump the size of the lumps that we operate on for breast cancer, I think the results might be comparable. Here is the procedure, mortality, and cure. Simple gastrectomy or less naturally has a lower mortality rate, naturally has the highest 5-year cure rate because they're the most favorable cancers. But there still is an appreciable salvage in extensive resections, including total gastrectomy, esophageal gastrectomy, and multiple organ resection of about 20%. Taking determinate cases as the baseline, that is, the patients who survived the operation, were not hospital deaths, and who did not die of other cause within the 5-year period, and determining the influence of metastases, 60% 5-year survivals in the partial gastrectomy group if lymph nodes were not involved, 30% if lymph nodes were involved. With the extensive resections, the lymph node influence is not so apparent, 20% for survival in both groups.
And this concludes the 7th edition of Audio Digest Surgery for 1971. Our thanks to all participants and to the Cleveland Clinic Educational Foundation for their cooperation in recording and disseminating this material. Just one quick note, our semi-annual Cumulative Subject Index, Surgery, Volume 17, for July through December 1970, has been completed and will soon be in the mail to you. Audio Digest Surgery is produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.